Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Dr. Mark Saleh. Dr. Saleh completed his undergraduate education at the University of Western Ontario in London, Ontario, Canada. He earned his Doctor of Medicine degree with honors from the University of Toronto in Ontario. He then performed postgraduate training in urology at the University of Ottawa, also in Ontario, Canada. Dr. Saleh is board certified with the American Board of Urology and is certified in urology as a Fellow of the Royal College of Surgeons of Canada. Dr. Saleh currently practices medicine with Washington Township Medical Foundation in Fremont.
So Mark Saleh, and I'm a urologist locally here at Washington Township Medical Foundation. We're going to be talking about prostate cancer, but I'm going to be talking about the prostate in general, the anatomy, enlarged prostate, as well as prostate cancer and prostate cancer screening. So this is basically a summary of our talk today. As I mentioned, the anatomy of the prostate in general, BPH, or benign enlargement of the prostate cancer, how prevalent it is, its consequences and treatment options, and prostate cancer screening and the controversy that's around that screening process. So what is a prostate? It is a male sexual gland. It's only found in males. It makes nutrients and fluid for the sperm. Most of the fluid that comes out with ejaculation in the semen is from the prostate, as well as the seminal vesicles nearby. Very little is actually the sperm itself. The fluid is added during ejaculation, and the urethra, where the urine flows through out of the bladder, goes directly through the prostate. So there's a bladder, there's a urethra going out through the penis, and this is a cross-section. The prostate surrounds the urethra. That explains the consequences of the enlargement or any disease of the prostate and how it affects the urinary tract, just by virtue of its location. So we'll begin with BPH, or benign enlargement of the prostate. It is benign, meaning it's non-cancerous. And hyperplasia just means an increase in the number of cells in the prostate, which causes the enlargement. It affects most men at some point in their lives. It is more common with age. The prostate continues to enlarge with age. So as you would predict, the prostate gets larger, you have more symptoms. And it affects the ability to urinate, it causes urinary symptoms, and that results in a decrease in the quality of life for many men. Here's the anatomy of the BPH. On this side is a normal bladder. The urine comes out of the bladder, through the urethra, and through the wide open urethra through the prostate. With BPH, or enlargement of the prostate gets larger on the outside, but also on the inside, squeezing the urethra. So there's a narrower channel for the urine to flow through. That causes the bladder, which is basically a big muscle, to work harder. And when you stress a muscle, it gets bigger and thicker. That might be a good thing if you're working out or bodybuilding, but for the bladder, when you get a thicker bladder muscle, that makes it behave less normally. It becomes more hyperactive and overactive, and that results in a lot of the what we call the irritative urinary symptoms, the frequency, the urgency, the lack of control. And then the obstruction by the prostate results in the obstructive symptoms, the weak urinary stream, the intermittent urination, stop and go, inability to empty completely. So again, this goes over the same thing. As the prostate enlarges, outwardly it also enlarges inwardly and squeezes the urethra, leading to those symptoms. It's extremely common. It affects more than 26 million people each year, men, that is. The prostate reaches what we consider a normal size in the teenage years after puberty. It's about the size of a walnut at that point. That's a normal size. Unfortunately, for some reason, it keeps enlarging. It's stimulated by the male hormone testosterone to keep getting larger and larger. And this enlargement continues throughout life. By age 60, about half of all men have problems with their prostate. And if you live long enough, you're basically going to have a problem with the prostate, at least with the benign enlargement. What are the symptoms? Again, we talked about the obstructive and the irritative symptoms. It's frequent urination, getting up at night to urinate, sudden urges and lack of control of urination, the weak stream, intermittency, hesitancy, the difficulty to get the urination started, and the incomplete emptying. So what are the consequences, the clinical consequences of this enlargement? LUTs, or lower urinary tract symptoms that we just mentioned. Chronic urinary retention, which is a gradual increase in the volume of urine in the bladder that you're unable to empty. It doesn't cause the same symptoms as acute retention, which is a sudden stopping of urination. That might happen because you have a really large prostate where your bladder is just barely compensating and just barely getting the urine out, and then something happens. You take the wrong medication, or there's inflammation or infection of the prostate that causes whatever is left of that urethra to shut completely, and then you can't void or urinate at all, and you retain the urine suddenly. Now in that case, that can be very painful, and you'll know it obviously. Will require insertion of a catheter in the emergency room or your doctor's office. Detrusor instability or overactive bladder, that results because of the thickening of that bladder muscle, leading to that frequency and the urgency. If you retain urine, and urine is rarely ever sterile, one of the defenses that we have to prevent infection is emptying that bladder out. If you're retaining urine, you retain bacteria in there as well. And then that gives it a chance to multiply. The urine acts like a culture medium and leads to urinary tract infections. Also, that not mentioned up there is that elevated residual, that extra urine in the bladder, can allow crystals, sediment, to precipitate to the bottom, and you can get bladder stones as a result. Blood in the urine results because as the prostate enlarges, you also get increased blood supply. You need more blood for tissue to grow. And some of those blood vessels can be very abnormal and can be very close to the surface of the prostate. So with the normal process of bladder emptying and filling, with straining to urinate or even straining to have a bowel movement, some of those blood vessels can burst, and can cause blood in the urine. As you saw from previous pictures, the prostate, part of it is actually protruding into the bladder. So bleeding from the prostate can end up in the bladder, and then you have it in the urine. Ultimately, if this is untreated, and in the worst case scenario, you can have kidney failure. When you're retaining urine, that pressure in the bladder backs up the ureters, the tubes that drain the kidneys, back up into the kidneys. And then that pressure is so high that the kidneys cannot overcome it. And they're unable to filter the blood. And at that point, you have kidney failure. That's in the most severe cases. As you can expect, the prevalence or the frequency of this occurrence of prostate problems increases with age. Not very common under 49, but really common in the 80s, where 80–90% of people virtually will have some symptoms related to their prostate at that point. Also, the negative impact on the quality of life can go across the board of different activities, from not getting enough sleep, not being able to work, not being able to enjoy recreational activities, can't stay on the golf course, can't go on a long car ride, watch a movie, etc., because of those urinary symptoms. Okay, so you have an enlarged prostate. What are your treatment options? If you have mild enlargement and the symptoms aren't too bad, basically it's watchful waiting. Keep an eye on it, do your regular screening, etc. If the symptoms are moderate enough to bother you or impact your quality of life, then you can consider medications. The first category of medications is called alpha blockers. Medications like Flomax, Cardura, Hytrin, Uroxetrol, there's a whole category of them. They all do the same thing. They don't change the size of the prostate, but they work on the smooth muscle around the prostate and the bladder neck. They basically help the prostate relax so that the urethra is functionally larger and you have a better flow of urine through the prostate. If that medication is not enough, or if it's not tolerated, or etc., then you can either replace it with or add a second medication called a 5-alpha reductase inhibitor. Basically, that's a fancy way of saying that it blocks the effect of testosterone on the prostate. It shouldn't affect the rest of the body, but the testosterone is still circulating. You have normal testosterone levels in the blood, but this medication stops the testosterone from stimulating the prostate to enlarge. And in fact, it will actually cause it to regress a little bit, maybe about 20% in volume if you take it long enough, about 3 to 6 months. So it will shrink the prostate, hopefully prevent it from getting any larger, and that can be enough to relieve the symptoms in many men. The next step after that, assuming those medications don't work or you're not tolerating them, is some sort of surgical procedure. The minimally invasive procedures, like a microwave procedure, involves putting a catheter into the bladder, a special catheter that literally will send microwaves or something similar into the prostate and heat up the tissue. And when you heat up tissue, it shrinks, proteins. So if you have ever cooked a steak or a hamburger, you'll see how with heat, it changes the volume, it shrinks it up. It's very similar. So when you shrink the prostate, you shrink it away from the urethra, you relieve the symptoms. A more effective and more long-lasting therapy would be either the laser or the TURP, the transurethral resection of the prostate. Both of them do the same thing. It's basically removing the tissue. It's like coring out an apple. The outside of the prostate stays the same, but the inside is cored out. You open up an opening in the middle of it, creating a tunnel through the prostate through which the bladder can empty more adequately. In the really severe cases, in the very, very large prostates, it's not feasible to do it with the scope and the camera, and you may have to do it with an open prostatectomy, basically with an incision just above or just below the belly button, and you actually go in there and remove all that prostate tissue, leaving the prostate capsule intact, which is different from the radical prostatectomy we'll talk about later for cancer. This demonstrates the result you will get with the laser procedure or the TURP. On the left side here is the enlarged prostate. What you're looking at here, this is the right side of the prostate, the left side of the prostate, and the middle part. And this little opening here in the middle is the only opening for the urination, for the urine to flow through. You use the laser to evaporate all this tissue, and now this is what you see. This is after it heals, this is initially afterwards. You have this whole large opening in the middle that actually is the new urethra now. And most men will have an excellent result after this for relief of their symptoms. So prostate cancer screening. It involves doing a blood test called a PSA, and we'll explain that later. The digital rectal exam, that dreaded finger exam, and that's often done by your primary care doctor. If there's an abnormal PSA or an abnormal rectal exam, then you're often referred to a urologist for further testing. Prostate cancer is very, very prevalent, and it has involved a lot of prominent celebrities that you may have heard of. So what is prostate cancer? Prostate cancer, like any cancer, is basically abnormal cell growth. It is a normal, what would have been normally a normal prostate cell, where something happens within the cell, in the nucleus, in the genes, that makes it go awry. It stops the normal controls that most cells have. So in every organ, the cells know when to grow and when to stop growing. When they meet other prostate cells, when the prostate has reached the right size, they typically stop growing. Cancer cells don't have those controls. They don't listen to the normal controls, and they keep growing and multiplying, and eventually they can actually spread outside the organ, which is the real sign of malignancy. So it can spread and invade other tissues, which is how cancer can impact your quality of life and your quantity of life. The reason screening is important, like many other cancers, is that early cancer has no symptoms. I often have men tell me, well, I know my PSA is elevated, I know the rectal exam is abnormal, but I feel fine. Why is there a problem? Why do you think there's a problem? And I have no symptoms. Well, luckily, if you get it early enough, prostate cancer doesn't have any symptoms. Most of the symptoms that men have are related to the enlarged prostate, the benign enlargement that we talked about earlier, and has nothing to do with cancer. By the time cancer causes symptoms, it's often too late to cure it. It may cause difficult urination as it enlarges locally and causes further obstruction. It may cause bleeding, and it may cause pain or other disability if it spreads to other organs. But again, at that point, it's metastatic and it's not likely to be curable. Some facts about prostate cancer. It is the most commonly diagnosed non-skin cancer in men. Melanoma and other skin cancers are more common in most people, but in terms of cancers of internal organs, it is the most commonly diagnosed cancer in men. It is the second leading cause of death in men after lung cancer. It has the best prognosis when diagnosed early, of course, when it is localized and can be cured. So there's different ways that urologists and pathologists stage prostate cancer. The T and M staging. The T staging is for the local cancer, the N is for lymph nodes, and M for metastatic disease. Focusing on the local prostate staging, the T1 means that the prostate cancer is not palpable. You can't feel it. You do a rectal exam, it feels normal. So that basically usually means that it's small, maybe microscopic, or at least it's deep within the prostate where you can't feel it. So that's the very earliest type of prostate cancer, and it's either detected because of an elevated PSA, or after you have, say, the TURP, the resection prostate for the enlarged prostate, and you get some of that tissue examined by the pathologist, and they just happen to find a small amount of cancer in there. T2 is when you could feel it. T2A, you feel it in one side of the prostate. T2B, you feel it in both sides of the prostate. So this usually means that it's more posterior in the back of the prostate, and also it is large enough that it can be felt. When you get to T3, that means it's extending beyond the capsule of the prostate. This thin, pictured orange layer here around the prostate is the capsule, and if it goes outside of that, you could really feel that sometimes. You could feel it as firm or really localized, and it's immobile. It doesn't move very well. It's outside where the prostate anatomy should be. And also you may see that on staging tests like an MRI or a CT scan where they could see that it's actually extending outside that capsule. The final stage would be T4, where it's not just beyond the capsule, but it's actually invading nearby organs like the bladder or the seminal vesicles nearby. Once it spreads to the lymph nodes or outside the lymph nodes to other organs, then that's where we have metastatic disease. What are your treatment options? It depends on several factors. The stage, how advanced it is, and the grade of the cancer as well, by the way, which is how aggressive the cancer is. Your age and your health at the time, and your personal preferences, of course, about the side effects, the risks and benefits of the various treatments. Watchful waiting is your first option. That's basically doing nothing active other than keeping an eye on the cancer with PSA testing, rectal exams, and occasional biopsies every 1 to 2 years to see if there's any progression. Surgery, or radical prostatectomy, that's where you remove the whole prostate, including the capsule and the tissue around it. External beam, or the traditional radiation therapy. Brachytherapy, or implantation of the radioactive seeds within the prostate. Cryotherapy, cryosurgery, where you freeze the prostate. There's also more experimental or second or third line therapies like heating of the prostate with ultrasound waves, which is not currently FDA approved. So we'll talk about prostatectomy. What are the goals of that? You're removing the whole prostate and hopefully the whole cancer before it has spread. So the only way the cancer could come back at this point is if it's already outside microscopically and we just can't detect it yet with our technology. The goal is to preserve urinary function. That means allowing you to urinate and hopefully control the urine without leakage, and also preserve erectile function. If you have normal erections before the prostate, hopefully you should be able to preserve those erections, possibly with the help of medications like Viagra or something similar afterwards. This is the anatomy. Bladder, prostate, the urethra going out under the pubic bone through the penis. These nerves here, these yellow things on the sides, those are the neurovascular bundle. That's what supplies the penis for the erections. And you can see they're literally plastered on the side of the prostate, on either side. There's 2 sets of them. And they're attached to the capsule. So they have to be gently peeled off that prostate to preserve the erectile function. That's called the nerve-sparing prostatectomy. Now sometimes if you're unlucky enough to have more aggressive disease where you have that T3 stage where it's going outside the capsule, the cancer might be invading one set of the nerves. So if it's invading it on the left side, you have to actually take the nerves on that side and preserve them only on the contralateral, or the other side, which reduces the chances of erections but still gives you some chance. So we're going to talk about PSA screening and the controversy about PSA screening right now. Here's what you need to know. What is PSA? PSA is it's a protein. It's actually an enzyme that's produced by the normal prostate. So every male with a prostate has PSA produced by the prostate, and it leaks into the bloodstream at a steady rate. The amount of PSA actually relates really well to the size of your prostate. So men with big prostates are expected to have a higher PSA. As we get older, the prostate enlarges and your PSA level is expected to get higher. For somebody in their 40s, for example, or under 50, we expect a PSA of 2.5 or less to be normal. In your 50s and 60s, a PSA of 4.0 is normal for you. When you get into the 60s and 70s, 6 or 6.5 might be acceptable. So there's no one cutoff that can be used across the board for determining what is and what isn't normal. What does it do? The main function that we think it does is it helps with fertility. It helps liquefy the semen. It helps give nutrition to the sperm, helps the sperm swim better. It may even liquefy the mucus on the other side, around the cervix, also to facilitate the swimming and the fertility. So basically, after you're done having kids, the PSA is no longer useful other than for screening. Now, 3 years ago, the U.S. Preventative Services Task Force looked at a bunch of studies. They looked at the risks and benefits of screening, biopsying, treatment for prostate cancer, etc. They came out against PSA screening. They decided that, in their opinion, that the harms from screening outweighed the benefits. Unfortunately, to my knowledge, there's no urologist on that panel, and they also didn't come up with an alternative. There's no alternative way to screen for prostate cancer that we have currently other than PSA and rectal exams. So basically, you either screen or you don't screen and you hope for the best. As urologists, we see those patients that come to us that have never been screened, who haven't had medical care, etc., who come with symptoms and with cancer that has already spread and it's too late to cure. So the American Urological Association does not agree with the U.S. Preventative Task Force. We believe that screening is still important, and we have to use the tools that we have available to us, and that is the PSA. So prior to April 2013, prior to that report coming out, the American Urological Association's recommendations were that you screen at age 50 all the way up to age 75, and you screen every year. For high-risk patients, we used to start screening at 40. After looking at the new studies and the U.S. Preventative Task Force recommendations, we came out with new recommendations as follows. For men under 40, you should not screen. They're very clear about that. Between 40 and 54, you probably shouldn't screen, but you could in some exceptions that we'll outline. Between 50 and 69, you should screen, but probably every 2 years, assuming that everything is normal, instead of every year. And for men age 70 or higher, you probably should not screen, but again, there are exceptions. So let's look at each one of those recommendations in detail. Men under 40. In this age group, there's a very low prevalence of prostate cancer and very low chance that finding prostate cancer will actually lead to any improvement in treatment. So you should not screen that population because you could actually do more harm. Between 40 and 54, screening is not recommended, but there are exceptions. If you have a first-degree relative, that is a brother or a father, with prostate cancer, if you're of African American descent, you're at higher risk of getting prostate cancer and a higher risk of getting high-grade aggressive prostate cancer. And in those cases, you should be screened at some time before 55. Probably at 45 to get an initial baseline PSA. If it's normal, I would repeat it again at 50, and then maybe every 1 to 2 years after that. For the age group 55 to 69, the recommendation is that you should screen probably every 2 years. The studies show that screening can be useful in this group. It has the most benefit and the least risk. We can prevent anywhere from 1 to 6 deaths, depending on how long you look. So if you look at the lifetime of these patients, you prevent 6 deaths for every 1,000 men that are screened, which I think is worthwhile if you're one of those 6 men. Screen every 2 years, but of course, if there is an abnormality in the PSA, you might want to screen more often or less often again, depending. If your PSA is less than 1, for example, you may want to screen even less often, because it's a very low level at that age. The lifetime risk of being diagnosed with prostate cancer is about 17%, or about 1 in 6 men will get diagnosed in their lifetime. The lifetime risk of actually dying from that prostate cancer is 3%. So 1 in 33 men will die from that cancer. So basically, many men will be diagnosed, only some are actually going to die of that cancer. And that's where screening and treatment becomes complicated. We don't know how to separate yet those men that may never die, may never progress, from those that will actually have aggressive disease that will impact their life. So we realize no screening test is perfect. Every screening test has to balance the risks of screening, the risks of the procedures and treatment that you may offer, versus not screening at all and missing those cancers. The risk is that, well, first, rectal exam before PSA used to be horrible as the only screening method. You would only feel those large cancers that are T2 or higher, and we would miss at least 2/3 of the cancers when they were curable. When PSA came along, combined with rectal exam, that improved things significantly, but it's still not perfect. PSA can be falsely positive. That means it can be elevated when there's no cancer at all. That can lead to a biopsy, and that can lead to complications by itself. Roughly at a PSA level of 3.0, which is rather low, I'm not sure why they did that in this study, 1 in 4 biopsies will be positive only. Now, if you use a cutoff level of 4 or 5, more of those biopsies are going to be positive. Probably 1 in 3 is more like it. So yes, 2 people might get biopsied and might have the complications of biopsy without having cancer, but at least they'll have the peace of mind knowing that they don't have the cancer. And you can be more comfortable about not screening them as often or worrying about them as much. For those people that get diagnosed, then you give them the option to get treated or not get treated, again, based on their own preferences and their own health. Why does PSA become falsely positive sometimes? Well, because it's not specifically for prostate cancer. It is released by the normal prostate, and in an enlarged prostate, a bigger prostate will make more PSA. So if your prostate is 80 grams, you're going to have twice the PSA as somebody with a 40-gram prostate. If you have infection or irritation of your prostate, that squeezes that PSA out of your prostate and makes the blood level go up. So if you happen to like doing exercise on a bike, or you do spin classes where you have this narrow little seat squeezing against your prostate for long periods of time just before you do your PSA test, that very well may falsely elevate your PSA temporarily. But that's one of the reasons that most urologists, all the ones that I know, don't biopsy based on one elevated PSA. You repeat the PSA, you watch the PSA over time, and what I find beneficial is to look at the pattern. The PSA may go up and down, but if the pattern over time, over several months, is an upward slope and it's rapidly rising, then that's going to be a lot more worrisome than one elevation in your PSA. And that's a better guide for me whether we should do a biopsy or not. Why worry about this? Why not just biopsy everybody with a slightly elevated PSA? Because it's an invasive procedure. It's done in the office, it's minimally invasive, it involves sticking a needle into your prostate. But that's still invasive. It can cause bleeding. It can cause swelling of your prostate that can cause retention of urine temporarily. Even though we do a bowel prep and give you antibiotics, some people will still develop infections in the urine or in the prostate, what's called prostatitis. And you can get fever and chills. You may need a longer course of antibiotics. Rarely, you may even need to be admitted for IV antibiotic therapy in the hospital. That's about a 4% hospitalization rate. So it's not completely benign, but it's the only thing we have that can confirm or not whether you have prostate cancer. At the other end, let's say you've had the biopsy and now you're diagnosed with prostate cancer, there are risks to that too. If your cancer is small and slow growing, and your life expectancy is less than, say, 10 years for other medical reasons, you have a bad heart, you're older than 70 or 75, etc., then just having the cancer may push you to get treated. You may not be able to sleep worrying about it. So that causes stress. Also, you may get treatment that may not be necessary, and treatment can cause problems. Radiation and surgery can lead to things like bladder irritation, rectal problems, incontinence, erectile dysfunction. So they're not completely benign either. So if you get treated for a cancer that's not what we call clinically significant, then that's the possible harm from the screening as well. How do you make those decisions? 60 out of every 1,000 men in that age group that we talked about, 55 to 69, will develop clinical evidence of prostate cancer, cancer that you can actually find, within about 10 to 14 years if they're not screened. So it may cause symptoms, it may be something that you can feel on prostate exam, it may cause some other metastatic disease, etc. 5 out of those 60 will die of their disease within those 10 to 14 years. So to summarize, prostate cancer is a very common disease. It can have an impact on how long you live. It can shorten your life. It can cause an impact on your quality of life. It may cause pain, bleeding, bladder problems, irritation, etc. PSA screening is not a perfect test. We realize that, but we don't have an alternative. And there are ways to deal with that imperfection and to mitigate that risk. The decision to screen or not to screen for prostate cancer comes down to you and to your doctor. It is something you should discuss based on your situation and your preferences with your own doctor, and before you decide whether you want that screening and how long to continue on that screening. Thank you.